Myelofibrosis is a really difficult disease to diagnose, I think. There's no like one lab test that you can do to help make the diagnosis, but most of the time, the diagnosis is really based on having a good clinical suspicion of having the disease. So for most patients, the diagnosis really starts to be considered when there are certain signs and symptoms of the disease. For some patients, it can be low blood counts, in particular anemia or thrombocytopenia. For other patients, it can be splenomegaly or an enlarged spleen. For many patients, it can be evidence of having scarring in the bone marrow that causes cells that should not normally be in the bloodstream more apparent, such as nucleated red blood cells. And once there's enough of a clinical suspicion, the next part of diagnosis is to do a bone marrow biopsy. And the bone marrow biopsy really is, there's two parts to the bone marrow biopsy. There's something called the aspiration, which is really used for evaluating the cytogenetics of the bone marrow or the genes that could be mutated. And then the core part of the biopsy is where myelofibrosis can be diagnosed based on the histopathology, how the cells look under the microscope. And then ultimately, the final diagnosis of myelofibrosis is made by meeting certain criteria based on the WHO, both clinically and histopathologically. I think the thing to know is that there is no one standard treatment approach for primary myelofibrosis. Each patient's treatment is really individualized. And so in general, for most of my patients that I see, the first thing I try to do is assess what their risk score is. And there is a variety of different algorithms out there to help determine what their risk is. The risk scores are sort of based on, they're designed to predict both risk. The risk scores are generally designed to predict the aggressiveness of the disease and help predict outcomes of the disease, meaning transformation to acute leukemia. The current NCCN guidelines really recommends that patients who have high or very high risk disease be treated with a JAK inhibitor, of which we now have many options, but a JAK inhibitor, and if they're physically fit enough, be considered for a curative therapy, such as a bone marrow transplant. Patients who have lower risk scores, such as one of the more commonly used risk scores is called the Dynamic International Prognostic Scoring System, or the molecularly inspired prognostic scoring system. So if patients have a lower risk score, there is really no standard of care for those patients. Treatment can be considered for patients who have symptoms of the disease, or many patients may simply be observed. I think it's important to note, though, that selection of a JAK inhibitor for patients it used to be that we only had one JAK inhibitor, ruxolitinib, and that was sort of universally applied. However, treatment with ruxolitinib often came with many challenges, amongst them myelosuppression, which in many patients who have myelofibrosis may have baseline myelosuppression, and that myelosuppression could have been made worse by ruxolitinib. And so my approach to choosing a JAK inhibitor with the advancement of many newer second generation inhibitors is to try to tailor the JAK inhibitor to the patient's presentation and their cytopenias. So for example, for patients who are severely thrombocytopenic, I may be more likely to choose pacritinib. For patients who are anemic, I may be more likely to choose momelotinib.